But currently I'm the only fellowshipped orthopedic traumatologist anywhere within the next 2 to 3 hours. So between here in Seattle, here in Spokane, here in Portland, sorry guys, it's just me. But that's what I'm here for, okay? So why did I come to the Tri-Cities? Well, this is an interesting map. This is a map that is put out by the University of Pennsylvania. And everywhere where you see purple, this is access to a trauma center within 1 hour. That's a level 1 or a level 2 trauma center. Where are we? We are somewhere right in there. And no purple is anywhere to be seen, okay? And so I looked at this as an opportunity with a growing population. We had some friends here who could give me a little bit of a scoop on what it's like to raise a family and things like that. And it seemed like a perfect opportunity. And Kadlec is actively trying to pursue a level 2 trauma designation. I'm not anybody official from Kadlec who can tell you what their timeline is, but it is moving forward. This hospital already sort of functions like that to a certain degree. But I saw that as an opportunity to come in and say, hey, that's a place where I can build. More importantly, they needed a brake specialist. I have a bunch of partners who don't like, it's not that they don't like to fix fractures, it's they like to do other things, and if they can let somebody else fix the fractures, they would prefer it. Their training is in joints, as you heard from Dr. Staley, or shoulder replacements from Dr. Gibbons, whatever it is, and I'm somebody who just likes to fix broken stuff. So my only disclosures for this talk is this pretty lady right here who's sitting somewhere in the middle of the room, and the 5 hoodlums that come with her. They're mine. Those are mine. Okay, so main objectives for this talk. Number 1, you can't catch a break, so how can you prevent one? Number 2, we're going to talk a little bit about something called Fosamax fractures. You may or may not have heard of these, so we're going to answer what are they and how are they treated. The hot button topic for an orthopedic fracture symposium for the experienced life traveler is always going to be focused on hip fractures. I'm sure everybody has some concerns about that, and certainly some folks in the audience have some experience as well. And then the last of it all, hopefully something that you get out of the whole thing, is how do you get back to life? Because that's the whole point. So first, let's take a step back and look at the scope of the problem. If you look at our country, the population here in terms of the geriatric population, and this is more specific to those who are 85 and older. Currently, we're sitting somewhere between 5.5 to 6.5 million people who fall into that 85 and older category. This is a symposium targeting those who are 50 and above, right? So some of you have this as a goal to get to, and gratefully so, because then you're going to be part of this 14 to 19 million later on, right? But you can see how this is an increasing trend. It used to be that the average lifespan was 50, right? Now the average lifespan is closer to 80 to 85. So the more life years that you have, the more experience that you're going to get, the less tread on your tires you're going to have, and therefore the more problems that arise. And just because that population is increasing, the things that those people are most concerned about, and as I'm sure many of you are, is your health. 60 to 65% of patients in that age category are most concerned about their health and what are they going to be able to do to stay as active and as healthy as they want to be. And you probably can't read this. I can barely read this. It says that it says 60% of them expect to stay at the same level of health over the next 10 years, even though most of them have chronic medical conditions. And so there needs to be a management strategy for all of that. As far as an aging population is concerned, if you look at osteoporosis fractures, you know, compared to heart attacks, strokes, and breast cancer, which gets all the publicity, osteoporotic fractures, there's 1.5 million of them a year. Heart attacks, 500,000. Strokes, 250,000. Breast cancer, less than 200,000. So these 3 things combined that take up all the news don't even come close to the number of fractures that are encountered because of osteoporosis. So it's a big, big problem. This is sort of a breakdown of that 1.5 million. When you look at them, almost half of them have to do with the spine. Okay? Another big chunk comes from the hip. We're going to talk about those. Wrist fractures are about 200,000. And then there's a whole host of other ones that are all combined to that extra 300,000. So these things are all bound to break. If you look here, this is 1993 down here. These are a type of femur fracture called a subtrochanteric fracture. These are acetabular fractures. That's the cup side of your hip joint that Dr. Staley told you about last week. And then these are closed pelvic ring injuries. What's the one thing you notice? They are all increasing, right? And I think that's in large part due to the fact that the population in that age category is increasing. So if you look at cost is another big deal. That 1.5 million costs about $18 billion a year to take care of. So this is not something that can just get brushed aside, okay? And there are people who've recognized this. There's a certain program called the Geriatric Fracture Program, which is a commercial entity that hospitals can buy into that provides resources, education, outreach, prevention strategies, things like that. But there's an investment up front, and not all hospitals have bought into that because it is a commercial entity, even though it has much to offer. I do have experience with that. I've been in part of that in other training environments compared to where I'm at currently. And we have something similar here at Kadlec, it's just, it doesn't have the official designation. But it's such a big problem that they even formed an international geriatric fracture society. So even though America seems to have the highest number of 85-year-olds and older seeking first world treatment, this is not just isolated to the United States and certainly not isolated here to Richland. So if you can't catch a break, we should at least define them, okay? So number one is an insufficiency fracture. Insufficiency fractures mean that under normal circumstances, you are simply walking down the street, suddenly you have increased pain. That is a clear identifier that your bones are insufficient to carry your load. Okay, we'll talk about some of those. The other more common one is something called a fragility fracture. And this is something that comes with a minimal mechanism of injury. A fall from standing height, fall out of a wheelchair, fall off your chair at dinner, whatever it is. You're not tumbling down the stairs 5 flights. This is you fall over. And there was a question in the back. One of the patrons had a question that I'll answer because she said she may have to leave. She asked, is it better to try to break your fall and avoid and run the risk of breaking an extremity, or just falling down and hope for the best? I said, well, it's better to break a bone in your extremity than it is to break your head. Breaking bones won't kill you quickly. Breaking your head will. And so that's my quick answer, just to get that off the table. Okay? So when we look at a diagnosis of osteoporosis, from an orthopedic standpoint, by definition, if you show up with an insufficiency or a fragility fracture, you have osteoporosis. It just doesn't happen in normal bone. Normal healthy bone does not break with such a low energy mechanism of injury. Even if you've had a bone mineral density study that says otherwise, you have osteoporosis by clinical definition. Then there's the testing definition, which is this next one. And this is done, many of you may have had this. Has anybody had a DEXA scan? So you all know your T's and Z scores and whatever else. So a T-score is what everybody refers to for definition of osteoporosis. And this is comparing your bone quality to a gender-matched control from their 20s and 30s. Okay? So right away, you have less tread on your tires, and now you're being compared to the 20 and 30-year-olds. Most of the time doesn't make most of us feel good. I'm in the middle of that section, and I still don't feel all that good about being compared to the 20-year-olds. Okay? Z-scores, however, you can be compared to your neighbor, but it doesn't give us any clinical diagnosis. Okay? So, my days of shooting from the hip are now numbered. So let's look at who gets these fractures. If you're looking from an epidemiological standpoint, Hispanic women are at the highest risk, and there's a lot of questions as to why that is. The thought process currently is mostly that their dietary calcium intake is very, very low. Rice and beans just, it's not going to cut it. And that is a gross generalization, obviously, but that's just the prevailing theory between why Hispanics seem to be the most at risk, and they certainly have a large number of them. And the Hispanic population in America is only increasing. So it's something that epidemiologists, at least, are paying attention to. I see a broken hip, I just fix it. When we go to Caucasians or Asian Americans, these are also at risk. Again, I don't think there's a clear answer as to why certain ethnicities seem to be more at risk, but I think most of it these days is the fact that we're no longer farmers out in the field all day long. We're inside an awful lot. And so vitamin D intake is low. Most of your vitamin D comes from sunlight, converting vitamin D in your skin and then sending it systemically to be activated. Well, when you're inside all day, the incandescent light bulbs just aren't cutting it. They don't do the same metabolic activity that we need that the sunlight gives us. Another interesting group are the African Americans. 10% of women over 50 in the African American population have osteoporosis, and 30% more have low bone density. There are over 300,000 African Americans who have African American women who have osteoporosis. And one of the interesting things is that of all the fractures sustained by African Americans over 64, almost 95% of them are due to osteoporosis. So you can see this is a big problem. One of the things that I thought was interesting as I was preparing for this is that African American women are more likely to die from hip fractures than white women. Now that's a little bit of a misnomer. Hip fractures will not kill you. The bone will not make your heart stop. It's the complications that come because of that and how you're treated. That's where the difference comes, okay? And we're going to get into that a little bit. What about the guys? The guys in the audience, I didn't want you to feel left out. But unfortunately, many of you are or may have osteoporosis or low bone density. It's underdiagnosed, underrecognized, underreported, and certainly under-researched. There's not a lot of funding that focuses on the guys. These two guys would just laugh at it anyway. But there's over 2 million American men who have osteoporosis, 3 million more who are at risk. 1/3 of all male hip fractures are related to osteoporosis. The other 2/3 are typically young adult males making stupid choices on motorcycles or other recreational vehicles. And unfortunately for the men, when they have a hip fracture, currently the data says they don't do as well after surgery as do the women. Again, gross generalization, take it for what it's worth. So let's look at the risk factors, okay? Number one, getting older. We still haven't solved this problem. I don't know how to turn back the clock, okay? Being female, having a thin or a small frame, having low body weight, poor health or frailty. Smoking is probably the #1 preventable risk factor that you could have, okay? And then a family history. Well, you can't really change your family. You got the genes you got, and so it is. Being postmenopausal, this goes back to being female, so the men dodge this bullet. But hormone imbalance is a big deal because it does affect the longevity of your bones and their overall strength, okay? There are eating disorders such as amenorrhea, anorexia, and bulimia that can actually bring this on sooner in life than it really should be. Low calcium intake, like we talked about earlier. There are even some medications that can stimulate this or be an underlying cause of poor bone quality. For the men, one of the things that we need to pay attention to is low testosterone. That's a real deal, and it affects a lot more than what the TV ads will tell you. It affects your bone quality as well. Having a sedentary lifestyle goes back to low impact and not having enough exercises. Your bones will thrive in an environment where they are constantly being stressed because then they have to adapt and respond. And if you're not stressing your body focuses its efforts on strengthening the things that are being used. Unfortunately, in America, most of the time, that's our abdomen. Okay? And then excessive alcohol intake. That's the other major preventable risk factor for low bone quality. You also look at impaired vision. It doesn't affect bone quality, it just affects your ability to protect yourself. There may have been some of you here who've experienced that at times. Okay, estrogen deficiency early on in age. having dementia. Again, you can't protect yourself if your cognitive function isn't up to par. Poor health, like we talked about, recent falls, lifelong low calcium intake, low physical activity, and a history of fracture. History of fracture is very important. And that's because that is the single biggest risk factor for having a subsequent fracture. If you've had a fragility fracture in the past, you are anywhere from 1.5 to 9.5 times more likely to sustain a subsequent fragility type of fracture. Okay? So, what are our goals here, right? The first goal is to prevent them. If I never have to treat another one, that means I did my job. Okay? It also means I can't feed my family, but it means I've done my job. Every year, there's more than 1.5 million older Americans who go to the emergency department for fall-related injuries. I'm not going to ask you to raise your hand, but I know there's people in here who've done this already. Fractures, or falls, excuse me, are the #1 cause of fractures, hospital admissions for trauma, loss of independence, which nobody wants, and injury deaths. Okay? The three factors that contribute to fractures are fall, force, and fragility. You could fall down the stairs with the strongest bone in the world, and you still might break. If you have fragility already and you fall down the stairs, you're going to break for sure. If you fall off a chair or from standing height, that's not much force. But then the fragility outweighs that. Okay? So, if we can't prevent it, then our next goal is to restore pre-injury function as best as we can. We want to do that in a timely manner. Why? To limit the amount of pain you have to go through and to prevent complications. Part of the recovery from that is then treating any underlying conditions, osteoporosis, thyroid issues, etc. And then lastly is making sure that we've got appropriate social assistance after surgery or after treatment if it's non-operative treatment. Okay? So, I'm a basketball fan. Does anybody know what help defense is? It's exactly what it sounds like. Your buddy is there to help you out. Okay? This is a slide that shows you, here's the ball here in the corner. This is this guy's defender. And here's his buddy coming over to help him out. Well, when he comes over to help him out, the rest of his teammates have to adjust for that. That's called help defense. So we're here to provide you with some help defense. And help defense from a fracture standpoint comes from a physiologic mechanisms, medical, psychological, and then environmental. So if you look at help defense from a physiologic standpoint, this is important because a geriatric syndrome, musculoskeletal frailty, this is a study done in 2012 that shows that musculoskeletal frailty is a geriatric syndrome at the core of fracture occurrence in older age. So we need to maximize our physiologic capabilities. Like these folks, they're getting some good impact exercise, hopping against osteoporosis. This is important because there's nothing that any of us can do at this stage of the game to change our overall bone mass. That all happened when you were about 20 to 30 years old. You hit something called your peak bone mass. And I hate to tell you, but it's all downhill from there in terms of bone mass. The things that we can impact is how quickly, or not so quickly, this slope goes downward. The flatter that slope, the better it is for us. That's where we can have our impact. God made it this way. We're trying to limit the effects of that. Okay? He knows what he's doing. I'm not going to negate that. But okay? Overall, we just know our bone's melting away. So what can we do to impact that? One of the best things that you can do is to stay active. Get exercise. Like we talked about, bones thrive under stress, under loads, of appropriate kinds. Bones don't do very well in tension. They break in tension, but they do great in compression. Compression comes when you let gravity take its toll. That happens by walking. That's one of the best ways. Now, we don't walk on our hands, and so our arms don't get that same sort of impact, right? But doing some weight training, things like that. So physical activity makes bones and muscle stronger, which helps us prevent bone loss. All types of physical activity, knitting, crocheting, anything that keeps you moving is important and part of staying healthy. High impact exercise programs may be the most effective at preventing fragility fractures. Okay? One of the next things we can do from a medical standpoint is get a diagnosis. Once you have a diagnosis, then we can treat you. Doctors will not treat you for things they have not diagnosed you with. That's the great mystery of medicine. It's our job to figure out what that diagnosis is. Okay? There are multiple medical conditions that may need a diagnosis that could then be treated. Thyroid and parathyroid, GI issues for absorption. If your gut isn't absorbing, you're not getting the nutrients your bones need. There's the effects of diabetes. Smoking and alcohol I've already touched upon. And then there's nutrition, things like vitamin D and calcium. Like we talked about, vitamin D comes from the sunlight. Okay? This is a pretty simple formula. Calcium and vitamin D make stronger bones. It is simplistic, but it's true. It's not going to negate everything that you've done, but it can decrease how fast that slope goes down. These are the current daily recommended intake for vitamin D and calcium. And we're focused today on the age over 50. Now, for vitamin D, I would tend to say at least 1,000 international units, and for calcium, at least 1,200 milligrams. Your doctors will direct you appropriately. There may be room to increase that, and oftentimes there is. Next thing we're going to talk about are the other, they're called anti-resorptive drugs. So when I said that from a medical standpoint we can control the rate of decline, this is where this comes into play. Okay? And that's because these drugs are very good at slowing down how much your body attacks itself in a manner of thinking about it. And there are a number of different types. There's estrogen or progestin, which is a hormone replacement like we talked about with menopause. That's a big deal for women. Bisphosphonates are the most common. These have been around the longest and have been FDA approved the longest. There's some other types, calcitonin, raloxifene. If you're on it, you'll love it because you need it and it was an appropriate diagnosis, but it's not for everybody. Okay? And then there is only one bone forming drug on the market currently, and even that has select indications and contraindications, and so it's not just something that from a simplistic standpoint you would think, hey, if it makes bone, shouldn't every orthopedic patient be taking it? Orthopedists want their patients to grow bone and to heal. Shouldn't everybody be on it? Well, there's complications. There's nothing that's goof-proof, okay? And so there are select indications. I'd refer you to your doctor to get those questions answered. So when you look at help defense, like we talked about, from a prevention standpoint, the bisphosphonates are approved by the FDA, like we talked about, to reduce or slow down how quickly you lose bone. These are some of the more popular and the most common. You may have heard the names Fosamax, Boniva, Actonel, Evista, or even Reclast. You may be on those medications. I have my hand is not in any of those baskets, so this is not a push for any single drug, okay? This is an example. This is that drug, like I talked about, that is bone forming. It's called Forteo. That's the trade name for it. It's a parathyroid derivative. Nobody really knows how it works. I've asked many endocrinologists, and they're scratching their heads. They just don't know. But it does, and that's what the studies show, and so sometimes you figure out why later on. Number one thing you can do, if you smoke, stop yesterday. Okay? And that's because smoking reduces bone mass. How does it do that? A single puff of a cigarette will reduce blood flow. The one thing your bones need to stay healthy, and all your tissues in general, is blood flow. If a single puff can do that, 2 packs, good luck. Okay, so that's the one thing that you can do. This isn't going to affect your bone quality, but it's going to impact how you use those bones. Dude, you got to get your eyes checked. It's important to stay safe. Vision's very important for avoiding obstacles and also for balance. Balance is an easy way to fall. The next type of help defense we're going to look at is psychologic. You can't just stick your head in the sand and say, yeah, it's in their mind, they'll be fine. It's not really true. Cognitive function and protecting that as best as you can be a protective asset for you. There are psychosocial support is critical to having a positive outcome. This was a study out of the American Academy of Orthopedic Surgeons that looked at psychosocial factors and surgical outcomes. And I want you to pay attention down here where it says psychosocial factors play a significant role in recovery and are predictive of surgical outcome. Attitudinal and mood factors were strongly predictive. That means the Debbie Downers didn't do well. And those that were happy and had good psychosocial support tended to thrive, or at least get back to where they were before. Obviously, like I said, we haven't figured out that whole turn back the clock thing yet, but they can get back to their normal function or what their pre-operative function was. So here's the stuff that is simplistic or seemingly simplistic. The environmental changes that have to take place for you to be protected, okay? We're going to talk about the simple ones first, and then we'll get into the hard ones. Simple stuff. Add handrails. Clean your house or have somebody else do it. Make sure that you've got a shower chair so you don't, or a rubber mat in the shower so you're not slipping. Bathrooms are one of the highest rated danger zones for elderly people, okay? Avoid wearing high heels. I love high heels personally because it's job security. But the majority of you, it's a danger. Okay? For the guys, most of you have no experience, so don't try now. All right? But sock walking, floppy slippers can be just as dangerous, and those are things that are seemingly comfortable at home, but in the wrong environment can cause injuries. Maintain a well-lit room. That goes back to the whole vision setup. Okay? Eliminate rugs, tripping hazards. Having a raised toilet seat. Make sure your tuchus can get down to where it needs to be and that you can safely get back up again. Clear the path to the bathroom. Okay? I would say that probably about 30 to 50% of the hip fractures that I deal with are from people who fell in the middle of the night with the lights off trying to get to the bathroom and they didn't see something that was on the floor. Or their foot tripped over a corner that they thought they had cleared. Okay? Clear the path to the bathroom. So here's the difficult changes. There's really only 2 of them that I came up with. This isn't any great study. There's no groundbreaking research here, but the number one thing that you have to get over is your pride. I have to as well. But why is that a big deal? Because there's a lot of people that say, I'm not that bad, I don't need a walker, I don't need a cane. And it's a pride issue. But when they fall and they get hurt, man, they get humbled real quick. And they realize, you know, life's a lot better not being broken. So if we can prevent it, let's do it that way. The other thing that you have to consider, and I totally understand, is your home environment. Some people build awesome homes, elegant homes when they're raising their families or in the prime of their career, and they stay in these homes forever because that's their home. I get it. My parents have been in their home forever. And it's time for them to realize that changes have to take place. And it's no longer, they can't take care of it, and it's just not feasible. There are obstacles that are not feasible for what they're going through. So, you may have to talk to your family members about what is our transition strategy for staying safe, okay? Other things to consider, the use of portable phones at home, keeping phones and electrical wires out of the walkways, having skid-proof backing on carpets. Again, this goes back to avoiding tripping and slipping hazards. Making sure that you've got at least a week's supply of your medications on hand. If you run out of medications and those medications are critical to your function and suddenly you don't have them for a few days, you don't function well. And when you don't function well, your bones get put at risk. And then you end up in my operating room wishing you'd never seen my ugly mug. So if you just keep a week's worth of medications, you'll be just fine. Okay? Probably the most important thing, and this again goes back to cognitive function and psychosocial support, is having 24/7 contact. Remember, when you were raising your kids depended upon you for life and limb every single day of their life until they could walk and talk on their own and not get hit by cars. Well, now the reverse is true. You invested in them, and now it's time for them to invest in you, if that's the option. And if not, there are a number of services who are more than happy to play that role for you and keep you safe. Okay? Now, we're past that whole prevention strategy to a certain point. We're going to talk about intended and unintended consequences a little bit. Okay? I'm going to tell you a story about a prevention strategy that is wildly successful, but in a very small population, and things that I've seen here and treated here that have an unintended side effect. Who's ever heard of this drug, Fosamax? Many of you are probably on it. Okay? This is a great medication. It was approved in 1995 by Merck, or by the FDA for Merck, and it prevents osteoclasts. Those are the cells in your bone that break down bone. In order for your bone to constantly regenerate, there's a balance between breaking down and building up. And when you limit the amount of breakdown, you would think, okay, well, the scale tilts in the balance of building up. All right? It does that to a certain degree, and that's how it has really decreased the number of osteoporotic fractures since it's come onto the market. Okay? Compression fractures is probably where it's had the greatest impact. And if you remember back to the slide of how the fragility fractures were broken down, it probably impacted vertebral compression fractures the most because there were the most of them. But no drug is perfect. And so in about 2007, 2008, the first reports of something called an atypical femur fracture started to come about. There were these patients who were showing up who described getting out of their car, walking down the street, and their femur breaking. And then they would fall. And that just didn't sound right. It sounded pathologic. But they would look at the x-rays and they didn't see any lesions inside the bone. There was no tumor, no cancer, no anything that could be specifically identified except for this little guy right here. Okay? This is what we call a stress reaction or a stress fracture. This side of the bone has the most tension of any bone in your body because of all the muscles around your hip and just the mechanics, the biomechanics around it. And so it's under a lot of force. So there's a great paradox here because Fosamax was made to prevent breaks. But what it actually was doing in a small subset of patients was making this bone right here extremely brittle. And the best comparison that we've come up with is chalk. When you push with chalk, it holds up really, really well. But if you gently twist it, it'll snap real quick. Your femur is not supposed to do that. That's not the way it was designed. Okay? So, as we've looked at this, there's something that's become apparent as these have become a little bit more common. On average, these patients were on the drug at least 7 years, but it did range anywhere from 1 to 15 years of treatment. Sometimes they had actually, if you look through the medical record, they had been telling their doctor that they had knee pain, thigh pain, hip pain, but they would take an x-ray and they didn't see anything. Well, when you take a hip x-ray, it goes from here to here. That lesion is right about here, typically. When you would take a knee x-ray, it would go from here to here, and that lesion is right here. So unless they were taking the appropriate x-ray of the entire femur, this little guy was getting ignored because nobody saw it. But as it's become more apparent, this is the thing that we've gone to. Okay? This is a study of mine that I did when I was in residency. And it looked at these fractures, so it's something that I'm very familiar with. And in this study, we had about 31 patients that had 43 fractures. So as you can imagine, about 10 or 11 of them had both sides. And it was amazing to hear their stories and to get to know what happened and the description of, yes, I was getting out of my car, walking down the street, and boom, my femur breaks and down I went. Just blew my mind. And so that's why I decided to do this paper. So it's something that we're very familiar with. But I don't want you to freak out. I'm not here to make you panic, I'm just here to make you aware. If you've got vague extremity pain, you've been on these medicines, if we identify them early, then we can treat this. You are more likely to be struck by lightning or killed by obesity than to experience this fracture. Okay? But recognition is key. If you can identify it, then we can take care of it. Oftentimes the treatment is as simple as just getting off the medication. Getting off the medication for 1 to 2 years after being on it for 5 to 7 years, because it is a good medicine and it's done a lot of good. And if it breaks, we fix it. If it doesn't break, we can try to treat it without surgery. And if that doesn't work, we can fix it, because our job is to maintain function as best as we can. Okay, so now let's get on to the juxtaposed jackpot of fractures. Okay? So we're going to talk about killer hip fractures that are no more killer hip fractures, painful pelvic fractures, rad radial wrist fractures, not so funny humerus fractures, concerning vertebral compression fractures. Okay? I hope this is not your misfortune cookie. Okay, the hip is the most common non-vertebral fracture site. Half of all hip fractures occur in patients 80 years and older. The incidence of hip fractures is going to approach 16 million. Now, if you think of that number right there, and you look back at our first slide about that aging population, that aging population is going to be correlated pretty close to a 1-to-1, right? I sure hope that doesn't mean that everybody's getting that. I think that this is an antiquated estimate, but again, that's in 80 years and older, okay? Hip fractures occur only a third as often as in men as in women. So the most important thing is to have early identification. That's why it's important to have daily communication or somebody who checks in with you. If you get to the emergency room faster, we get you treated faster, we get you back to life faster. So if you go down, we want you to get back up. But if you're broken, that's not going to work. So we get you to the emergency room. It's important that the emergency room doctors become educated in these hip fractures, because they need to give me, when they're calling me at 3 in the morning and I'm groggy-eyed, I'm listening for key phrases that help me to know what I need to do and how to prepare the OR so that all the appropriate stuff is in line and in place for you to be treated appropriately. There's an operative urgency. We used to think that patients are too sick to go to surgery. That somehow, some way, laying in the hospital and having multiple doctors come in and out and talk about their medical problems would make them better or more stable for surgery. And they'd be there for 3 or 4 days and then get surgery. That thinking has completely reversed. Patients are now too sick not to go to surgery, because it's when they lay in bed that they have problems. Okay? Afterwards, we want to make sure that postoperative care with a dedicated geriatric or geriatrician is important. Making sure medications are balanced. Making sure that you have what you need when you're done. And then getting you up and getting moving. For those of you who know me or who have had the unfortunate mispleasure of being my patients, you know that the first thing I tell you is, if you've had a hip fracture, you're going to get up and you're going to walk. I expect it this afternoon. I don't take no for an answer. Okay? And then having a rapid transfer to a rehabilitation unit if it's appropriate. Hospitals are full of sick people. You're not sick people, you're hurt people when you break your hip. If you stay in the hospital, you'll become a sick people, and then you'll be there even longer. And nobody has time for that. So the other thing I want you to be aware of is that beware of false knowledge. It's more dangerous than ignorance. Everybody's heard the story of my mother fell down, she broke her hip, she died 3 weeks later. That is more often not the case, particularly in this day and age. 20, 30 years ago, that may very well have been more common, but that's because that thinking of how to approach surgery is different. These are the lessons that we've learned. There were conflicting results about whether or not morbidity and mortality was increased or unaffected by delayed surgery. But the one thing we know for sure is that getting to surgery in less than 48 hours reduces your hospital stay. If you reduce your hospital stay, every other study seems to tell us that you're going to reduce complications and mortality. Okay? I'll tell you that since I've been here, our average of time to surgery from the moment a hip fracture patient hits the door to the time they hit the OR has gone from about 30 to 35 hours down to about 17 hours or less. Oftentimes it's even less than that, okay? And that's because this is a big deal. And I am in the fortunate position of being the one to take care of those patients. I don't have to balance it with an elective hip and knee schedule, which is what Dr. Staley does. And that's not a knock on him. He's got people that he's treating for other issues. And this is what I love to do. So I make myself available for it, okay? And the hospital has made room for me to be able to do that. If they don't give me an OR room, I still can't treat you any faster. I'm sorry, I'm not going to do it in the emergency room. It's not right. Okay? This is a study done in 2011 that looked at 92 patients, and they were looking at a specific time point, and they said a delay to the operating room more than 4 days increased 6-month and 1-year mortality compared to doing it within that first 48-hour window. Okay? So that seems to be the magic number, and there's more recent data that is coming out looking at surgeries done less than 12 hours, less than 24, to see is there a magic time point where those outcomes start to decline. Because obviously we don't want to be on the downslope, we would love to be on the upslope. We want our patients to do well. So there's some key anatomy here, and we're going to focus on femoral neck fractures. When you break the neck of the femur, it's going to look like either one of these top two that are essentially non-displaced, meaning the ball has not kicked off of the stem, or it's going to look like one of these bottom two, where you can clearly see that the ball has moved off of its attachment. If it has not moved, it's pretty simple. You fix it. Some of you have experienced this. You've gotten 3 screws from me. Your hip's been fixed. We get you up, get you walking. The bone heals, and it's great. When it heals, it's great. When it's displaced, the head is dead, and you've got to replace it. Okay? Were any of you at this Grateful Dead concert in 1972? Okay. Just checking. When you have a displaced femoral neck fracture, there's 2 options in my book. You look at a total hip arthroplasty. These are typically for metabolically or physiologically younger patients who tend to be more independent. They have higher functional expectations. So we do a total hip, okay? If you don't seem to follow into that category, then we do something called a hip hemi-arthroplasty, which these are typically patients who have a little bit more experience in life, are a little bit more dependent on the care of others, and have lower functional demands. So rather than replacing the ball and the socket, we just replace the ball, get you up, get you moving. Ultimate outcomes are hopefully the same. You get them up, get them moving. That's the goal. Okay? So what happens when it's not a femoral neck fracture? Well, when it's this other type of hip fracture called an intertrochanteric fracture, then we talk about fixing it. And there's 2 main strategies for that. You get a screw and a side plate, which has been around for ages, or you can get a nail, and that's done through, I don't know if anybody here has had that. I'm trying to look around and find a guilty party, but I'm not going to point you out if I do. But if you've had this, it's done through 2 incisions about that big, plus or minus an additional incision that's about the width of my finger. So I like to consider this minimally invasive, makes me feel sexy, makes me feel like I'm a good surgeon. But the reality is, this is how we fix these breaks, okay? Most importantly, both of those constructs allow you to get up and put as much weight on it as you can, because they're designed to generate compression through that break right there. And what did I tell you about bones? Bones love compression. That's how they heal. So what are the need-to-know items? First thing you need to know is that almost all hip fracture patients are weight-bearing as tolerated, meaning you can get up and walk right away after surgery. Number 2, look at number 1. Number 3, look at number 2 and number 1. Those are the most important things. After that, you need to know that you're probably going to be put on a medicine to prevent a blood clot. That is the one thing about hip fractures. You do have an increased risk of blood clot. That's the one thing that will kill you quickly. Ain't nobody got time for that. I certainly don't. You certainly don't. So we try to prevent that with a medicine. Then afterwards, we talk about where do you go. You can either go home to an inpatient rehab facility, or to a skilled nursing facility, and we'll talk about that a little bit later. Okay, so that all looks good. We're done with the hip, right? So let's look at outcomes. So when you look at outcomes for hip fractures, and this is again to go back and tell you, hey, things are going better than you think. When you look at co-management between a geriatrician and an orthopedic surgeon, co-care for the older patients with hip fractures was associated with significant reductions in morbidity and mortality and increases in optimal postoperative care. That's my journal. I didn't write it, I don't own it, but that's where most of my learning comes from. That's a peer-reviewed article. So this is good stuff. Hey, here's another one. This is a systematic review, which means they looked at a ton of different studies who generally focused on this same topic, and they tried to conglomerate all of that information into one big study. And the one thing they saw when they again looked at orthogeriatric care was there's a significant reduction of in-hospital mortality, long-term mortality, length of stay was significantly reduced. That's good for everybody as far as I can tell. I don't know anybody who wants to stay in the hospital any longer than they have to. I certainly don't. I know you certainly don't. Okay? Alrighty. Anybody an Elvis fan? Okay. So we've got Elvis the pelvis. So these are very common. This can be from a fall from standing height. And when we talk about insufficiency fractures, like I mentioned earlier, where it breaks under normal weight bearing, this is where I see it the most, is in the pelvis. When you get a break right here, the important part of that is most of your weight bearing is done in the back and through the hip joint and not up front. So if you break this little guy, yeah, it's going to hurt, but it's not going to prevent you. It's not dangerous for you to get up and go, okay? But these are very common and they do hurt. That's because the pelvis is like a pretzel. When you were a kid, your pelvis was like a soft pretzel. It could break in one single spot because it's a little more pliable. Bone as a kid, it's more like cartilage until you're a late teenager, early adult. When you're an adult, through most of your adult life, you were like one of these guys, a regular pretzel that had some durability, some strength. It was great for dipping, okay? As you age, you become more like this pretzel, where it's much more brittle. Your 2-year-old grandson can easily break it, right? It happens. The pelvis is a pretzel, what can I say? Fortunately for you, and for me, there's a quick return. Typically, no surgery is necessary as long as it is a stable injury. The mainstays of treatment are therapy. We have some therapists in the crowd. Some pain medicine. And then, as it goes back to that whole pride thing, you may need to use a cane, you may need to use a walker. And that's okay. It keeps you safe. All right, let's get on to the rad radial wrist fractures. Okay? Don't hit your doctor. It's not covered by insurance. That may or may not be true. So, very similar risk factors for all this fragility fracture. Typically, to address the point that was brought up earlier, it happens with a fall onto an outstretched hand. You try to prevent yourself from hurting other things. Again, breaking your wrist, yeah, it hurts, and there's some lifestyle changes that occur afterwards, but it's better than being dead. And so I would encourage a wrist fracture over a brain fracture, if that's even a thing. So the treatment most of the time depends on handedness, your fracture pattern, and your pre-injury function level. Okay? You can clearly look at this x-ray and say, that ain't right. And so when you go to the emergency room and that shows up, hopefully the emergency department is willing to do what we call a reduction, or try to set the bone. That may be the term that you're familiar with. Okay? Other possible treatments for this include casting or a surgery. Surgery includes plates and screws. It may include pins going through your skin into the bone to hold it, or something called an external fixator, which looks like a bar and pin contraption that holds your bones in a relatively stable position until your anatomy and your biology can fill in the gaps. Okay? After treatment, oftentimes we'll send our patients to a hand therapist who focuses on these injuries and can maximize your function. If you're a right hand dominant individual, the last thing you want to do is have to learn to be left-handed when you're 75 years old. I mean, school was hard enough when you were young, and trying to do that at 75, not fun. Okay? Let's look at the proximal humerus not so funny fractures. Okay? I was waiting for the chuckle. I appreciate that. This is how they happen. Again, addressing the point of what do we fall on? If we have to fall, what do we fall on? Well, again, if you can prevent yourself from hitting your head by hitting your shoulder first, yeah, it's a better alternative. It's not ideal. I understand that. There's 4 different parts to the proximal humerus. This is called your greater tuberosity. That's your lesser tuberosity. Your surgical neck is right here, and your anatomic neck is right there. Okay? So we talk about severity based off of the number of parts of the break that are involved. And depending on the pattern will dictate your treatment. What are your treatment options? Being really, really happy in a sling like this guy. Sometimes we do pins. I will be honest with you, I have seen this once in my life. The patient hated it. I think my boss who did this got it out of a textbook written in 1942. But it works, and there are a lot of places in the world that that's the most advanced technology they have, and so that's what they use. And so it does work. It's a viable option. Most of the time what we're seeing now, if it has a surgery, oftentimes you're ending up with some type of plate and screw device or some sort of intramedullary nail, similar to the femur or the hip. Okay? There are replacement options as well, a hemiarthroplasty. That allows you to maintain function without the pain, which is great. But then it's like recovering from a rotator cuff surgery. And if any of you have had those, you understand that that's not a fun recovery. 3 to 4 months down the road, you'll like your surgeon again, but not until then. There's another replacement option called a reverse total shoulder, and I'm not sure if you heard from Dr. Gibbons if he brought this up, but this is becoming a more popular way to treat some of these complex shoulder fractures, because just like a just like a total hip replacement, it maximizes function utilizing what they have, what the patient has, without placing them at risk for increased harm. If you didn't have a rotator cuff that was functioning very well and you fell down and broke your shoulder, this is a great option because it eliminates the rotator cuff from the equation of recovery. It focuses more on your deltoid. And most people still have a functioning deltoid. That's your big shoulder muscle, your chicken wing. Okay? The best treatment is a tincture of time for all of these breaks. God designed our bodies so that they would heal. And bone is the coolest tissue in the body because it's the only tissue in the body that heals with itself. Bone heals with bone. Everything else heals with scar. You have a heart attack, as your heart heals, it fills in with scar. If you have a break that goes into your joint and it hurts your articular cartilage, many of you have heard this spiel, it heals with scar. And we just can't predict what the function is going to be like when it is scar. We know how bone functions. We've studied it for eons. And we know that when it heals very well and heals strongly. It's when it doesn't heal that it becomes a problem. Okay? Commonly, it will take about 3 to 4 months or 12 to 16 weeks for x-rays to show final healing, sometimes longer. Again, it depends on where we started with your bone quality, what medical problems you have, and what we need to do to maximize that. Okay? So from my standpoint, it's important to understand expectations from the patients. Every patient is unique. Having your dominant versus your non-dominant shoulder will impact your outcomes. Whether you're active or sedentary, independent versus dependent, there's a difference between expectations and reality, and that's what I need to understand. From the practitioner's perspective, I'm focused on trying to get people back to moving. So I want early motion. I want to avoid stiffness. Stiffness is a very, very hard problem to overcome. So we send you to therapy for range of motion, okay? I will often tell my patients that we don't start strengthening until you get your motion. So it's incentive for them to regain their motion so then they can start building up. We say that motion is lotion. Anybody here like lotion? My wife's guilty. Motion is lotion. If you don't have motion and you start to strengthen, your muscles are going to shorten at that limited capacity to move. And then you're never going to get your full motion back. So we optimize our motion as much as possible. The other things that we're looking at is we need to know about rotator cuff function and viability when we're making a decision on the shoulder. And that again goes back to what type of procedure would we do. I need to know that you're going to be safe at home when you go home, because it's going to impact what type of procedure are we going to do. And that's true for any of these fractures, but particularly the shoulder. And then we talk about the surgical risks. There's a lot of bad stuff that lives around your shoulder that nobody likes to see and nobody likes to get into. And so you need to be aware of that. And we have a full conversation about, hey, if I cut in here, I might see some stuff that I don't want to see. There's nerves, arteries, vessels. If they get in the way and they get cut, well, we got a bad problem. It's a real risk. Most of the time it doesn't happen. Surgery is very safe, but it's not without risk. Okay? So let's talk about vertebral fractures. We're concerned about their compression. I told you that bones love compression because that's how they heal. The spine tends to love compression a little too much. And so it starts to compress as time moves on. It weakens the underlying structure, and so they start to collapse. You'll look here, of all the fragility fractures, vertebral fractures are almost half of them. Then the hip, then the wrist, and then everybody else. So what do we need to know about vertebral compression fractures? Number one, I'm not a spine surgeon. I'm going to defer most of the questions to the spine guys because they're the ones who are going to treat them. I am telling you about them because it does fall into this great syndrome of fragility fractures that we're talking about. These can lead to progressive deformity and pain. As it does that, deformity leads to further imbalance. You start to see that kyphotic posture, which changes your center of balance, your center of gravity. And as that happens, you start to become front heavy. And when that happens, you're going to topple over forward. When that happens, then you're having a conversation with me. And nobody needs that. Okay? There are some treatment options. They're designed primarily at trying to restore the anatomy or restore the function of the spine. That spine is designed to take you from this and do what your mothers all taught you and stand up straight. Otherwise, it's pain control, physical therapy, and then there are surgical options, one in particular called a kyphoplasty, which is demonstrated here. They put a special balloon into the bone, inflate it to jack the bone back out to its normal height, or as close to it as they can get, and then inject it with cement. And it's a good option. But it's not goof-proof. Because if you put cement here, the bone here, and the bone here, probably is just as unhealthy as this guy that you just inflated. And so sometimes it puts adjacent segments at risk. So again, that's where we ask you to ask the spine surgeon whether or not it's right for you. So where do we go to next? When we talk about getting out of the hospital, the first and best option for everybody would be to go home. That's typically a plausible answer for those who are of the highest functioning nature, who have safe home environments and caretakers available to help them. You may require some medical equipment, a walker, a ramp, a shower chair, whatever. The next option would be to go to an inpatient rehabilitation unit. The requirements for that are after surgery, you have to be able to withstand 3 hours of what they consider to be intense physical therapy a day. And you have to get past the medical director or whoever it is that's making the decision about whether or not you can get admitted there. Plus, you have to make sure that your insurance company covers it. There's a number of hoops that have to happen, but from a functional standpoint, that's a good option to have somebody watching you and guiding you in getting better. And if not, then going to a skilled nursing facility is an option. And they do have rehabilitative services there who can help to maximize your function. And as you slowly progress and increase your independence, you can then return back to whatever prior living situation you were in, or they can help facilitate what your next transition back into life is going to be. So, what are we going to have you guys do next? Number one, when you go home today, look around your house. How can you improve your personal safety at home and abroad? What can you do? I'd have you talk to your doctors about what can you do to maximize your bone density. Is exercise safe for you? Can your heart withstand some of the rigors of exercise? Are there other exercises that you could do? Do you need more vitamin D? Are there any other prescriptions? Things like that. The other thing to look for are warning signs. If you, like we talked about with the Fosamax fractures or the atypical femur fractures, if you've been on that medication, I don't want you to go home and say, wait, was that my femur? Oh, I think I feel it. I don't want you doing that. I want you to live life. But if you experience those things, I want you to pay attention to them and seek out appropriate care. Okay? And one of the best things you could do, go home and call your kids. And if you don't have kids to call your neighbor, call your friend. Have emergency contacts, have regular contact with somebody who's going to check on you.